Hello everyone, it's Clare Snowden here. I'm from the London School of Hygiene and Tropical Medicine, and I'm one of the chairs of the HTMR Trial Conduct Working Group, which is hosting this webinar. This is the first webinar of 2017, and we have a really nice full programme this year. You're very welcome to join us. We've got about 45 people registered today, which is a really nice number, and it's good to have you here. And if you have colleagues who might be interested in the topic today who can't attend, there will be a recording available afterwards to you, and you'll receive an email about that with a link. I'm pleased to introduce Clare Relton to you today, who's our first speaker. Clare's a Senior Research Fellow at the Sheffield School of Health and Related Research, and her clinical background is in homeopathic medicine. Her DH Doctoral Fellowship was awarded in 2003, and she told me that this is when she developed her interest in how to design trials of real-world interventions. She has an interest in ultra-pragmatic RCT design, and you'll hear a lot about that today with her talk about the Twix design. And I heard Clare speak recently on this, and it is a very interesting area. I'm sure it will lead to some discussion. She leads the Yorkshire Health Study, which is a population-based health behaviour cohort. She also has an interest in interventions which will improve how we feed ourselves at a societal level, and she currently leads the MRC-funded financial incentives for breastfeeding trials. So although there's a lot there that we could talk to Clare about, we are going to focus on Twix today. So Clare, over to you, please.
Hi Claire, hi everybody. Thank you very much for inviting me. So today I'm going to talk about what are Twix and how they're being used. So this is an approach to pragmatic trial design that we've been developing here at SHA, at University of Sheffield. So basically, in a nutshell, it's using cohorts of people to facilitate the conduct of multiple randomized controlled trials. And it's especially useful where the trials have status quo control arms. So by that I mean treatment as usual, or no treatment, or usual care, whatever the phrase, whatever the phrase is. So it's an approach to it's a design approach to pragmatic randomized controlled trials. We first published the methodological article describing the design in the BMJ in 2010, and the title of the article was Rethinking Pragmatic Randomized Controlled Trials, introducing what we then called the Cohort Multiple Randomized Controlled Trial Design. It was a terrible name, nobody could ever remember it, so we've sort of so people sometimes refer to it as the CMRCT, the Cohort Multiple Randomized Controlled Trial Design, or and then the last couple of years we've actually just used the abbreviation Trials Within Cohorts. So if you hear those phrases, Twix and CMRCT, they're basically the same. So apologies for all the language issues there. So the rationale for actually having a rethink about how to design pragmatic randomized controlled trials is manifold, isn't it? So the first and obvious one is recruitment issues with regards to pragmatic randomized controlled trials. As we know that it's very difficult to recruit. I gather now that 50% of MRC and HTA trials are recruiting to time and target, whereas whereas 70%, only 30% were managing to do that about 10 years ago. And the other challenge for recruitment to trials is often that the populations that we recruit are often not representative of the population to whom we want to generalize the results. So recruitment, that's what the key issue. And then there's ethical issues. So the information we give in trials when we are recruiting people to trials, we often give information about treatments that then half the people are not then offered if they're randomly selected to the usual care group, and we inform people that their allocation to treatment will be decided by chance. And that leads to a whole complex variety of ethical issues, which I'm not going to go into at the moment, but we'll unravel a couple of those later on. And then there's the questions around the scientific and just the financial efficiency or inefficiency of our current approach, where we know that and I'm sure you all have all read many reviews of trials in the evidence base for your particular clinical area, and the majority seem to me seem to conclude that well, apples and pears, what I call an apples and pears conclusion, which is basically, well, there's several trials or many trials in this area, but because it's different study populations, it's different outcome measures, it's due to the variety, the heterogeneity in the trials that are out there, we've got an apples and pears situation, so it's very difficult to actually summarize the results of the evidence base. And then we also know we've got many, many questions that we all want to answer, to get rigorous answers to. Yet we know trials are phenomenally expensive, at averaging £1 million each, and they answer at least just one or two questions. So there's a big mismatch really in terms of our standard approach to randomised controlled trials and the needs with regards to efficiency, the needs with regards to addressing the ethical issues, and need in terms of regarding the challenges that we have for recruitment. So that's just a whistle-stop tour of the rationale for us having a go at rethinking our approach to pragmatic randomised controlled trials. So, trials within cohorts, or cohort multiple RCTs. So what are the key features of this design approach? Well, the key thing is you identify and recruit a large observational cohort of people with the condition of interest, so the condition of interest for you, for your research question, and then you set up a regular measurement of their outcomes. So it could be daily, weekly, monthly, yearly, decadally, depends on your particular research question and the resources you have. This cohort then provides a capacity for embedding multiple trials within it. Then for each trial embedded within the cohort, you identify those who are eligible for that particular trial. You randomly select a proportion to be offered the intervention. And then you compare the outcomes of those randomly selected to the intervention with those not selected. And then the last feature is you use what we called patient-centered informed consent. I'm not sure how wise that phrase was, but we were trying to convey something there, which I will talk about a little bit later. So if we sort of take a step back, how do trials within cohorts compare to the standard approach to pragmatic randomized controlled trial design? So in the standard approach, each trial recruits its own population, which at the end of the trial is very often then disbanded. Everyone who's approached is offered full information about all the possibilities, all possible things that might or might not happen to them up front at the beginning, before the trial starts. And their consents are sought for all possible scenarios. So do you consent for this scenario, this scenario, this scenario? If we compare this to the trials within cohorts, or the TWIX approach, this uses cohorts with long-term follow-up, which then facilitate multiple trials. So the trial population isn't disbanded, it's recycled almost. And the information that's provided is done in a way which we call patient-centered, but I'm sure there's a better phrase, but it tailors it to the person, to the time, the resources that are available for that person and the group that they've been allocated to. So what information is conveyed to people, who it's conveyed to, and when it's conveyed is done to suit the needs of the patient rather than the standard way of giving everybody full information prior to the start of the trial. So let's have a look at some examples about how this is being used. So this is a sort of whole project flow diagram for something called the present cohort, which is a cohort over in Utrecht, the University Medical Centre there, of patients with bone metastases. This is another one also over in Utrecht of breast cancer cohort. So these cohorts have now got I think 2,000, 3,000, 4,000 patients each. This is a flowchart for a trial embedded in a cohort of children at risk of severe mental illness over in Dalhousie University over in Canada. And then I just wanted to have a look at the flowchart for the breast cancer cohort, just as an example so you can see how things work. So So let's have a look at this in a bit more detail. So as you can see, this is a CMRCT or a Twix informed consent flow diagram. And this is a variation called the stage informed consent. So it's got what they describe as 2 stages. So I'll flick to the next slide, which describes the first stage. So, so in this cohort, so this is a breast cancer cohort, patients arrive at the hospital and they, before they actually see their clinician, they are talked to, they have a visit, they have an interview with the researcher who describes the umbrella, it's called the umbrella study, and the research that's happening. And they're asked if they will give consent for their data to be used for the research. If they say no, then they don't participate in it and they just go on to their clinician and they have treatment as usual. But if they say yes, then they are also asked for further consent or broad consent for randomization, which is due consent in the future to be randomly selected for an experimental intervention. And also due consent to serve as a control without being recontacted. So basically we're asking people to say, hey, if you're in a trial, if we run a trial, say in 6 months' time or 3 years' time, and can we contact you if you're randomly selected to be in the intervention group, something other than usual care? And also, do you consent for us to not come back to you if you're actually in the control group? So do you consent to being in the control group where you will just continue receiving usual care without being approached again? So that's the first stage of consent. And then the second stage is so when the trial inclusion and exclusion criteria have been applied, and if we look at the right-hand side, so those who've consented, they're randomized to either receive the experimental intervention or not. And those that are randomly selected are asked for their consent to actually receive the intervention. But those randomly selected to serve as controls, they're not further informed that they've been randomized. I hope that makes sense. Let's move on. So how are trials within cohorts being used? So they're being used in 10 different countries now. Studies using the Twix design have got ethics board approval. Most of them are happening in Canada, the UK and the Netherlands at the moment. And the cohorts that are being recruited are in a variety of settings. So some are in hospital settings, so we've seen 2 examples there, and some are in primary care, and then there's a couple that are population-based as well. The cohorts, the populations that are being recruited, some of them are treatment-seeking populations and some of them are not. They're not non-treatment seeking, or populations that are seen as being at risk of various types of diseases in the future. And the types of characteristics in terms of the disease profile of the cohorts varies. So this is a list. It's not definitive, but it's nearly definitive, I think. So ADHD, cancer, depression, rare disease, hepatitis C, HIV, hip fracture, IBS, long-term conditions, etc. And the populations that have been the cohorts vary in terms of early life, young teenagers, young indigenous populations, older people, the elderly, and those who are recruited because of just where they live, the geographical region. The study that we're running here at the University of Sheffield is called the Yorkshire Health Study. So we're looking at a geographical region. It's a regional-based population, i.e. Yorkshire, who are seen as being at risk of multiple long-term conditions. So that's just one example. So types of interventions that are being trialled in these trials within cohorts, some of them are preventing, some of them are interventions looking at managing or treating disease. A whole variety of interventions are being trialled, everything ranging from acupuncture to surgery. And the comparators, the usual care or status quo, treatment as usual, no intervention groups, that's a characteristic of trials within cohorts, is they always have a status quo or usual care comparator, or standard of care. There's a new one that has just got HTA funding for a standard of care comparator trial. And there's a couple of examples where people have actually built cohorts, and they've, as well as embedding pragmatic randomized controlled trials, they've also embedded a placebo-controlled trial as well. But there, the standard approach to informed consent is taken, so people are told prospectively that they may or may not get a placebo. Some studies use multiple arms, so i.e. more than two, and some studies are also making use of the fact that because it's easier to recruit, because people are given the information at a time that they want it, that they and you can recruit in one fell swoop, rather than have to wait prospectively for every patient to arrive through your door. Many studies are using unequal randomization, so 1 to 2 or 1 to 3 randomizations, so with smaller numbers being in the intervention group. They're collecting a variety of outcomes, so patient-reported outcome measures. Some studies have got routine data linkage as well. Some are collecting biobank specimens, so it varies quite a lot. So embedding trials within cohorts. So cohorts can facilitate randomized controlled trials. These cohorts can be used to identify and screen potential trial participants, and also for other types of studies as well. And then they can collect outcomes for the trial, for each trial that's embedded. So a question that people quite often ask me is, well, how do you start these up? Well, looking at what people have been doing over the last 5 or 6 years, some build a cohort and they've already got pre-planned 4 or 5 trials that they want to run, and they obtain the funding for the whole show. Some build a cohort and then go and identify trials and seek funding for each individual trial. And some, very cleverly, they actually get the funding for a trial and then they build the cohort around that, and then they embed more trials within the cohort. So the funders, there's quite a variety of funders now of these types of studies. So in Canada, there's CIHR, in the UK, the NIHR, and also charities are also funding studies using this design. So they're either condition-based, and then in the UK, there's the big lottery is also just put funding into the a large project which uses the Twix design. So that's the Born in Bradford Better Start. I've put in £49 million. So, going back to the key features of the trials within cohorts design, let's go back to that interesting key feature, the key feature 7, patient-centered informed consent. So, what do we mean? Well, when patients are approached to take part in trials, a lot of different types of information is provided, all in one fell swoop. So, can we use your data to improve long-term health of the population? Can we contact you again? Can we look at your health records? Do you give consent to act as a control? We give you information about potential interventions, and we also tell people about that their selection to the intervention or control depends on chance, random selection. So we provide all that information. It's a lot of different information for people to take in, and as we know from the literature, people's understanding of informed consent, however well it's implemented by those taking informed consent, if you talk to people a day or a week or a month afterwards, the amount of information that they can remember from the informed consent procedure is often very, very small. So in terms of our rethinking of pragmatic randomized controlled trials and how we provide the information and obtain consents, we sought to divide up the information and the consents in a way that would make sense to the patient and the clinician as well. So we thought that the information about the potential interventions that are being trialed, the potential, i.e. that somebody may or may not get it if they join the trial, and the information that the selection to the intervention would be decided through chance. We've just called that therapeutic-related information, and so we've separated that out from the other information, the 4 top bullet points. So yes, actually, let me just go back. So so we've been very careful about how the timing of the delivery of the therapeutic-related information in the informed consent process. And what we've tried to do is mimic what happens in routine healthcare, in that patients are not told prospectively about interventions that they might not then be able to have. And patients are very rarely told that their treatment will prospectively be selected by the toss of a coin. So we've delayed, well, we've changed the timing for that information. So I'm now going to give you 3 examples of how these 20+ studies that are using the trials within cohorts approach, how they've chunked down or how they've staged the information and consent that they've been delivering to people. So I think there's many different ways of doing this, but I'll just give you 3 examples, but I'm not saying that these are hard and fast rules. It's just an example of a rethinking of the way that we approach informed consent, particularly for pragmatic trials where some people in the trial will not get anything different from their usual care. So, yeah, so there's variations in the specificity and the timing of the therapeutic-related information given and the consent sought. That is the information about potential interventions and about how people will be selected to interventions. So, yes, so I've just looking at what's been going on, I've identified 3 variations, which I'll go through in more detail. And I'll give you some examples as well. So the first one is where no information is given about potential interventions that are going to be trialled with people in the cohort, and no information is given that about random selection either. But information is given that we're studying this particular condition, that we'd like to contact you again, we'd like to use your data to improve for our analyses so we can actually find information out to improve the delivery of healthcare in this particular area. So we give all that information up front, but we don't give information about potential interventions or randomization. And then there's 2 examples of that. So one is being led by Rudolf Uhr over in Canada. It's the one I mentioned earlier on. And this is a cohort study of children who are at risk of severe mental illness. So they've got a very strong chance because of the high number of risk factors that they have. They've got a very high chance of developing severe mental illness in later life. So this is a platform. So yes, and there's several trials ongoing in that one now. So if you want to have a look at that, so that's a really interesting study. And then there's the one we're doing that I mentioned earlier on, the Yorkshire Health Study. Was originally called the South Yorkshire Cohort, but we changed the name. And there, we originally in our cohort, we said we would identify and recruit 20,000 people, adults in the Yorkshire, in the South Yorkshire area. And when we were constructing our application to the Ethics Committee Board, we tried to think, well, how many trials are we going to be running in this particular cohort? And we hypothesized that we guessed that we'd be running, say, 5 trials in the next 5 to 10 years. of interventions for this particular population, and with maybe 400, a maximum of 400 in the intervention arm of each of those trials. So that meant that over the, say, 10-year study duration, that there'd be 5 trials with 400 people actually randomly selected to be offered an intervention other than usual care. So that's around 2,000 people, and what we thought was, well, do we want to tell 20,000 people that they may be randomly selected to try something when actually, in fact, only 2,000 will? So this is the argument we put to our local NHS Research Ethics Committee for using this approach to informed consent where no information was given about interventions or random selection, and they were happy with that approach. So that's what we've been doing. So that's the first approach. Another approach is where some information is given. So this is so a nice example of this is a cohort of a rare disease, scleroderma, that's based in Canada, but it's actually, I think, now running in 9 countries. And there they tell people joining the cohort that potential interventions are going to be tested, but they never use the word chance or random selection. And they justified that by doing a lot of engagement with people in the scleroderma community, and decided that would be the most appropriate approach. A third approach is one that's being pioneered by the people over in Utrecht in the Netherlands, and this is where the information that there are potential interventions and that the allocation to the interventions is through random selection is given at a very early stage, well before the trial actually starts. And then when people are randomly selected to the intervention group, then they are informed about that. So this is the approach that's being used by all the cohorts running in the Netherlands. So there's 2 examples there. And this particular approach to informed consent has now been formalised and designed and reported by Danny Young-Affat in the Netherlands, and it's called they call it the stage consent design, but I've also heard it described as the 2-stage consent design or pre-randomization broad consent. So a whole variety of different terms there. So in conclusion, well, one of the things we wanted to do was, when we sort of did our rethinking, was we wanted to see if we could create an approach to pragmatic randomized controlled trial design that was more efficient than the standard approach. And so that question still remains open, as we still don't know whether it is more efficient than standard approaches. There are examples now coming out that recruitment is certainly a lot faster. Yes, so there's some good examples that are coming out, but they've not been reported yet in the literature due to the time lag that occurs. But we would need to actually collect some good empirical data in the long term in order to be able to determine whether it is actually a more efficient approach. We've seen that there's a variety of ways in which the design is being implemented in terms of populations, settings, the pacing, and also the approach to informed consent. And we've seen that there's generally been a positive response from funders and ethics boards, not just in the UK, but in quite a few different countries. So if you'd like more information on, please do contact me. And also we've got a great network now, or growing network of trialists who've got quite a lot of experience in using the design. And we've also got a website. It's in its very early days, but we're trying to put up information there so to help people, to guide people, so they can get information when they're designing their studies. So that's the twix.global. And you can also see information about events we've had. We've had 2 symposiums on the event on the design now. So one in 2014, when we brought together trialists who'd started using the design to talk about their experiences. That was a fascinating event, and the consensus was that we needed to talk about the ethics of the design. So 2 years later, in November last year, we held another international symposium on the design, on the Twix design, but this time focusing on ethics. And we brought together a broad group of people, including trialists and trial methodologists, ethics boards, regulators, and bioethicists, to talk about their perspectives on the ethics of the design. So that's it from me. If there's anybody interested in asking any questions, that would be great.
Thank you very much, Claire. That was really interesting. It was just as interesting this time as last time I heard you talk about it. If anybody does have any questions, we have a Q&A box at the bottom there if you'd like to put some in. So that would be really great to hear from you.
Sorry, Claire. I'm Relton at CTSU technically hosting this webinar. It seems like that Q&A box might not be working.
Oh, that's a shame.
If you attendees have questions, could you please send your question to chat box, or alternatively using the raise hand function, then we will unmute you.
Lovely. Thank you for Relton. It's good to have your technical advice. So yes, if you put anything in the chat box, that would be great, or raise your hand. In the meantime, and we've only got probably another 5 or 6 minutes, so you will need to be quite speedy. In the meantime, I'd like to pick up on some of the ethical issues that you mentioned, Claire. You said there was the symposium recently to explore ethics a bit further. Obviously, it's a meaty subject, but you also said that the design has been quite well received by ethics committees. Could you just give us a little idea about the sort of the flavour of the ethical discussions about the design?
So I'm quite often contacted by people preparing their ethics board application, and so we have a discussion about what they want, and then I ask them to let me know afterwards, but generally it seems that ethics boards don't have a problem with the design. But with the caveat with that is that in Holland they fought hard for for the first approach, which was no information is given about future interventions or randomization, and the ethics boards there were not happy, so they developed the stage-informed consent design for the ethics boards in the Netherlands, and that's going through well now. I haven't yet heard an example where somebody has got funding for a Twix design where they haven't got ethics board approval. So that's what I say.
Okay. So you seem to be having a bit of a smooth run with it so far.
I mean, sometimes they need to go and talk and dialogue, but it's never been held up massively or been refused, to my knowledge.
Okay. Interesting. We do have a question from one of the participants, Kenny Blades. I don't know whether you can see it, Claire, but I'll read it out in case you can't. Do patients remain in the cohort after taking part in an interventional trial? And is there any risk of recycling patients selecting positive responders for future interventions? So do you want to deal with those as two separate questions?
Yes.
Okay.
So everybody in the cohort stays in the cohort, and they may be invited to take part in a trial or not. And then going on to your second question, so they stay in the cohort because the long-term observational cohort is the basis, is the platform for the facilitating of the multiple trials. So people stay in the cohort for as long as they want, for as long as they're happy for their whatever the requirements are of being in the cohort are being met. With regards to the danger of being recycled for another intervention or for another trial, yes, there is that, and that needs thinking through. That's a question that, again, some people who are doing cancer research over in the Netherlands are now addressing, because they've got multiple trials ongoing. And sometimes, and then they have to go through the question, well, should we offer this patient, should this patient be in this trial or not? And there they have to just go back to the real world questions they're trying to answer. So sometimes the trial is of an intervention which is unrelated to the previous intervention they had. in which case, yes, they can be in the trial. But if it is related to it, then they may not want to. So basically, you need to keep on going back to the real-world questions, research questions you're addressing, and think, well, is it a problem that this patient is in this trial or not? So use a common sense approach.
So can I ask something that extends from that? So if you were using this design for a drug trial, presumably you would have to be careful about, although they wouldn't be running concurrently, there may be some issues about consecutive drug trials. Has that been considered at all?
Okay.
If the same patient was invited into 2 trials?
Okay, so drug trials, there isn't a drug trial using this design up and running yet, but there's just been HTA funding given for an osteoarthritis trial using this design, and they're at the moment in discussions with MHRA around what approach they're going to take to providing information and giving consents. So I think that's a question that we'll be able to answer once that trial's up and running and a little bit further on. So it's too early to say yet.
Okay. Well, I think we're actually pretty much out of time. We've got another minute or so. If there's anything, if there are any finishing words that you do want to.
Sorry, Claire. There is someone who has raised his hand.
Oh, sorry, I can't see that.
Yogesh Josh. Shall I unmute him?
Yes, okay. And as long as Claire doesn't mind, we'll continue to chat. Lovely. Thank you.
Okay.
Thank you.
Yogesh, could you speak out?
Yeah, hello.
Hello?
Can you hear me?
Yeah?
Hello, Claire. Can you hear me?
Sorry, I'm afraid your voice is very faint.
Hello, can you hear me?
Not really.
Hello?
Can you
hear me?
Yes, I can hear you now.
I wanted to ask that by referring to cohort population, what is the minimum population you can take to carry out the cohort research? Does it differ from disease to disease, or like when you are applying for genetic disease, does it is different or what?
Sorry, I couldn't hear that question. Did anybody else hear it?
I think there was something about the minimum population that you could use. Is that right?
Yeah. Okay.
But I couldn't hear the other details.
Okay, so I'm guessing that your question's around sample size. So how big a cohort do you start with? It's a really, really good question. I think you have to sort of look long term, sit there as a researcher and a research group and think, well, what questions do we want to answer, and when do we want to answer them by, and how many interventions are we going to be trialing, and then you have to sort of do your sample size backwards. So, like I said, described with the Yorkshire Health Study, if we're going to do 10 trials, we're going to need this number, and then therefore we're going to have this size cohort. We have to take into account attrition. So it's you have to do it backwards. I'm very happy to, if you want to email me, we're very happy to discuss it. It's a different way, different approach to sample size calculation.
Okay, thank you.
Okay, thank you. Rionfa, is there anyone else with their hand up, or have we covered everyone's questions now?
No, we think we have covered all questions.
Okay, well, thank you very much, Claire. It's really interesting, and everybody will be getting a link via email to this session. And Claire, if you want to post your link on your website, then this would be available through that route as well. Lovely, thank you. We have another webinar coming up next month. That will be Louise Bowman, and we've got a nice full programme for most of the year sorted out. So you'll be able to hear about that and see the titles and the abstracts soon. So you're all very welcome to come back. And thank you for joining us today. Thank you, everyone. Goodbye.